Dear students, from today onwards, we are going to start a new series of instructions to you. These are not routine didactic lectures. They will be advanced diagnostic triage and evidence-based management, specially curated for PGs, postgraduates of internal medicine in GEMS College. Regarding my background, you would have already known something. Some of them are listed here on this slide. But nonetheless, more important thing is the content rather than this slide. Okay. So we now go on to approach to chest pain, a bedside assessment, clinical reasoning, and triage. GEMS Medical College, Internal Medicine, from Dr. Sharma. Okay. A patient has come with chest pain at 2 a.m. in the morning. You are with very great difficulty. Why this man has come at 2 o'clock? You are just got into the emergency. Okay. Accepting the triage nurse's label as indigestion without you properly examining the questioning will lead to a pitfall. What you have to do? Debiasing, wiping the mental slate before crossing the threshold. Keep your slate clean. Don't come with a preformed idea that this is going to be gas trouble, this is going to be some costochondritis or something like that. Keep the slate clean with open mind approach. Prematurely, if you stop the diagnostic hunt and finding some epigastric tenderness, some relief with antacids is not the way to diagnose chest pain. The probabilistic reasoning is important, filtering the symptoms through physiological likelihoods. And finally, avoid misdiagnosis of atypical ACS. Everybody will say, if somebody is having low blood pressure, hypotension, and then there is already diaphoresis, intense chest pain, previous history of myocardial infarction, no need to tell he is myocardial infarction only. It is only the problem is when the misdiagnosis occurs in atypical cases. That is where accurate triage is important. What you have to do? Debiasing and keeping your slate clean, probabilistic reasoning. What is the pretest probability of this person having acute coronary syndrome, and appropriate triage. Okay, you must understand fundamentally the difference between visceral pain and somatic pain. What is somatic pain? It is from the parietal pleura, it is from the skin dermis, it is from the muscle innervation. Character is sharp, knife-like, pleuritic. Patient localizes, pinpoints with precision. Yeah, this is the painful area, sir. This is the painful area, sir. This is the, with one point, one finger point, he will pin. That is somatic pain. Okay. Whereas visceral pain, it is autonomic system overlap is there. Character is deep pain, heavy pain, aching, squeezing. Localization, very diffuse. Difficult for the patient to pinpoint with one finger. This is called Levine's sign. What is Levine's sign? Patient is not able to pinpoint the pain to one particular segment or point on the chest. Means it is visceral pain. Somatic pain, parietal pleura, from the dermis, from the muscle innervations, sharp, knife-like, pleuritic, patient can pinpoint. Why this happens? You have to understand. Previously, these words were in use. Typical angina, atypical angina, non-anginal pain, like that. Avoid that. This is totally unacceptable. The word atypical is banned from international literature as far as cardiac pain is concerned. Why? It breeds complacency. Okay, a 75-year-old diabetic woman with nausea has cardiac pain until proven otherwise. Take it as a dictum. Now, what is the classification? Cardiac pain, ischemia is the primary concern, possibly cardiac, ischemia cannot be confidently excluded. It replaces the dangerous and ambiguous atypical label which historically harmed women, diabetics, and elderly. These three, women, diabetics, and elderly, present with atypical presentation, atypical chest pain, angina equivalents, not typical chest pain. If you put them as a typical chest pain, you will lose them because of the you have prematurely shut off your window. What you have to do, these are also probably cardiac and evaluate. Of course, non-cardiac ischemia highly unlikely based on clear somatic visceral pain and alternative features are visible. Whatever I am talking is from standard international guidelines as on 2026. Most of them are after 2020 to 2026 we are using. We are using American College of Cardiology, American Heart Association, terminology paradigm matrix. What did we learn on the slide? No typical, atypical, non-anginal. Cancel. Wipe it off from your mind. What is the present terminology? Cardiac, possibly cardiac, and non-cardiac. Now, these are the red flag signs, anatomical red flag map. Why? Chest pain here is not somatic pain. The chest pain from the heart is a visceral pain mediated through the autonomic nerves along with the somatic nerves around the heart. There is a referral pain driven by C7 to T4 dermatome. So C7 to T4 dermatome overlap cardiac afferent sympathetic nerves. And radiation, classical radiation down the ulnar aspect of the left arm. By C7 distribution, C7 to T4 distribution. And important thing is dyspnea and diaphoresis. Sudden unexplained diaphoresis or shortness of breath in an elderly diabetic patient must be categorized as cardiac pain unless proved otherwise. This is what is called anginal equivalent. What is angina equivalent? Unexplained sweating, shortness of breath in an elderly diabetic female patient to be categorized as cardiac chest pain, anginal equivalent. Inferior wall ischemia. Heart has got, any box will have how many surfaces? 6 surfaces, right? This box, heart has got 4 surfaces. The anterior surface, the lateral surface, the inferior surface, and the posterior surface. There is no right surface, there is no superior surface. Because right surface, anterior and posterior merge, superior surface, anterior and posterior merge in the top. So now we have the 4 surfaces. The infarctions can be 4 types: anterior wall, lateral wall, inferior wall, posterior wall, or a combination of those things. Okay. Now, having said that, the inferior wall ischemia often misframed as gas trouble. People will come and say, sir, I'm having pain here, gas trouble, give me some gas medicine. They will become gas. If you treat them as gas, an inferior infarction, sooner he will be in the gas burner. Nausea and vomiting are true anginal equivalents of inferior wall infarction. You see here, patient presenting with nausea and vomiting and no typical chest pain should always be considered as inferior wall ischemia unless otherwise ruled out. Absence of classical chest pressure does not rule out ischemic heart disease. Look for autonomic equivalents. What are the autonomic equivalents? Dyspnea, diaphoresis, nausea, vomiting, upper abdominal disc. Radiation to the jaw, radiation to the hand. Any one of the areas it can radiate. Why? This is a combination of autonomic pain along with the somatic distribution from C4 to C7 to T4. Okay. Now, So the hemodynamic examination dashboard, what I should look for? Pulse asymmetry, a difference of more than 20 millimeters of mercury between both the arms or distal pulses is a red flag sign. It is aortic dissection. I have diagnosed n number of cases by this simple parameter. Just to feel the right pulse and the left pulse. The left pulse is weak. Look at the blood pressure. More than 20 millimeters difference between the arms. It is aortic dissection. Then a multiphasic friction rub. That means it is there in the inspiration, it is there in the expiration, it is there when you stop the breathing also for a while. That is called pericardial rub. And third, keeping the patient in the leaning forward position indicates pericarditis. Valves, new, harsh, holosystolic murmur at the apex suggests papillary muscle tear rupture, an acute complication of myocardial infarction. An early diastolic murmur suggests acute aortic regurgitation or proximal dissection. What I should look for? Pulse asymmetry, pericardial rub, and heart murmur, a holosystolic murmur, new onset holosystolic murmur, or an aortic regurgitant murmur at the proximal dissection of the aorta. Do not listen to the lungs. Feel the radial and femoral pulses simultaneously. It takes 3 seconds and can save a life. Lung examination comes secondary. Feeling both the side pulses and then looking for the new murmurs and pericardium. First of all, if a patient with chest pain comes, you must exclude these big six. What are they? Acute coronary syndrome, squeezing pain, radiating pain, diphoresis, S4th gallop, new murmur. Aortic dissection, sudden tearing, ripping pain radiating to the back. Listen to the patient. Unfortunately, today, you are all oriented towards investigation, CTs, PET scans, and all that. You never listen to the patient. Listen to the patient, the forgotten art of clinical examination. If you listen to the patient very clearly tells a tearing, ripping pain radiating to the back, and there is a pulse deficit between both the arms. There is a neurological deficit because of the dissection. There is an AR murmur because of the aortic dilatation. I am dealing with an acute life-threatening emergency, aortic dissection. It is much more dangerous than acute coronary syndrome. So you cannot miss aortic dissection. How do you get it? Sudden tearing, ripping pain radiating to the back, pulse deficit, neurological deficit, AR murmur at the aortic area. Acute coronary syndrome, squeezing pain, radiating pain, diphoresis, S4 is there, new murmur at the apex, holosystolic murmur. Pulmonary embolism, another most dreaded complication in clinical practice. Pleuritic pain, dyspnea, recent surgery, or patient traveled long distances in the flight. There is venous thromboembolism, consequent pulmonary embolism. Examination, tachycardia, right heart strain signs will be there. Tension pneumothorax, sudden sharp pain, severe dyspnea, tracheal deviation, breath sounds are absent, hyperresonant note is felt when you see. This is tension pneumothorax. Treatment is entirely different. Cardiac tamponade, chest fullness, dyspnea, Beck's triad. What is Beck's triad? Hypotension, jugular venous distension, muffled heart sounds, pulsus paradoxus. That is cardiac tamponade. Esophageal rupture, intense pain after severe vomiting, subcutaneous emphysema. These are the big six. You cannot miss the big six. These 6 conditions mandate immediate rule out before any diagnostic pathway is pursued. Any diagnosis is later on. First, you have to ascertain, are you dealing with acute coronary syndrome, aortic dissection, pulmonary embolism, tension pneumothorax, cardiac tamponade, or esophageal rupture. Now, the stable diagnostic matrix. These are not immediately dangerous. First one is pericardial and myocardial. Pericarditis, myocarditis, sharp positional pain. In one position, it is more better when he is leaning forward, preceding viral illness, a friction rub. This is in all phases of respiration. It is pericardial. Gastrointestinal conditions, gastroesophageal reflux disease, esophageal spasm, peptic ulcer disease. The pain is more burning, postprandial, worse in the supine position, relieved by antacids. Musculoskeletal, costochondritis, rib strain, highly localized, highly reproducible. Costochondritis is you will have pain, and at the exact point you press it, oh, same pain, sir, I'm getting. He will say. Exactly reproducible with palpation, worsens with the movement of the torsus. If you move the upper body or the chest this way or that way, the pain worsens. That is MSK, musculoskeletal pain. Psychogenic or other. Never dub chest pain as psychogenic unless you have evaluated thoroughly. Panic disorder, and I have diagnosed chest pain as herpes zoster in many patients. Because all other signs are absent, there is a pain radiating like this. After 3 days, the vesicles have appeared. That means it is a pre-herpetic neuralgia before actually the vesicles form. Clues are diagnosis of exclusion, hyperventilation, hyperventilation will be there, and in psychological disorders, dermatomal vesicular rash, if you see, it is herpes zoster. Never diagnose costochondritis without explicitly pressing on the chest wall to reproduce the exact pain. If you cannot reproduce it, it is not musculoskeletal. So these are the clues. Now you go. This is called the heart score. HEART. As per the AACC AHA guideline. Heart. Highly suspicious history. Patient has got acute pain, diaphoresis, elderly person, diabetic, highly suspicious history, 2 points. Moderately suspicious, 1 point. Slightly suspicious, 0 point. ECG, significant ST depression, 2 points. Non-specific repolarization, 1 point. Normal ECG, no points. Age, more than 65, 2 points. 45 to 65, 1 point. Less than 45, 0 point. Risk factors. More than 3 cardiac risk factors are there. For atherosclerosis, 2 points. 1 to 2 risk factors are there, 1 point. No risk factors are there, 0 point. Troponin value more than 3 times the upper normal limit, 2 points. 1 to 3 times the upper normal limit, 1 point. Normal troponin value, 0 points. This you have to do. Every patient, after excluding the big six, you have to do the heart score. Not at all difficult. History, ECG, age, risk factor history, and then troponin. What is the triage now? Anybody who has got 7 and above, immediate invasive strategy. That means they are having highly suspicious, the 2 point significant depression total. If all the 5 boxes of the red ones are positive, it will be score of 10. Anything 7 to 10, immediate invasive strategy. 4 to 6, observe, admit for testing. Less than 3, 0 to 3, save, and you can discharge early. The chances of major acute coronary events is less than 2% in them. This is called heart score. The mnemonic heart is H history, E ECG, A age, or risk factor, T troponin. Now, so patient has entered into your chamber, into the casualty or emergency ED, undifferentiated chest pain. He will not come with a diagnosis of infarction. He says he has chest pain. Step 1 is use ACC history and hemodynamic examination dashboard, which we have already discussed. Then, are the red flags present? What are the red flags? Hemodynamic instability, pulse asymmetry, tearing pain. There is fall of blood pressure, tachycardia, and SpO2 low, pulse asymmetry is there, tearing pain, red flags are present. Then immediately activate emergency pathways, big six management, prepare for cath lab or CT, cardiothoracic surgery. If it is dissection, you require cardiothoracic surgery. If it is ACS, you require reperfusion. No, he does not have the red flag sign. Then what do I do? Go to step 3. Then I do the heart score, which I have shown you in the previous slide. Then categorize them. What are the 3 categories? The extremely high category 7 to 10, then 4 to 7, 4 to 6, and less than 4 or 3, 0 to 3. So if it is 0 to 3, you can discharge. Second group, you have to keep and evaluate. The higher group, 7 to 10, this is cardiac. The second group is possibly cardiac, and third group is non-cardiac. Avoid atypical, typical, non-cardiac, all those things. You whole terminology you avoid. Now, what is the fourth step? Immediately draw blood for troponin. That is called 0-hour troponin. Then after 1 hour, one more troponin should be done. And after 2 hours, one more troponin should be done. What troponin? Not the ordinary troponin. HS troponin, high sensitivity troponin you have. This is available now. It is highly useful as an evaluation tool. How many samples are required? The first sample, 0 hour, 1 hour, and 2 hours. What is important? The rising troponin trend or the delta, the shift from 0 hour to 1 hour, 1 hour to 2 hour is more important than the absolute value of the troponin. Don't depend on the value of the troponin. It depends on the escalation speed with which it escalates between 1 to 2 hours. Patient data, 68 years old male, history of type 2 diabetes, severe heartburn, indigestion after dinner, blood pressure is 110/70, heart rate is 95, respiratory rate is 18, oxygen is 98. Triage nurse has written, patient is given GI cocktail, sir, I have PPI, I have also given some antacid, and she is awaiting the physician. You are already biased. Oh, looks like it is heartburn and so it could be gastric trouble, and you are in trouble now because the patient will become gas. What you have to do? Framing the bias, labeling indigestion primes the physician for GI pathway. Framework application. He is a diabetic patient. There is a visceral autonomic overlap. Epigastric is equal to cardiac category, which we have already shown in the slide 4. Do not defer to GI matrix. Immediately order a 12-lead ECG. Diagnosis, inferior infarction. Many patients are diagnosed by looking at this way. Patient data, clinical case 2, 54-year-old male, history of poorly controlled hypertension, sudden, sharp, 10/10 chest pain. If you ask him to rate the chest pain, 10 out of 10, yeah, he says the worst pain I ever had. It is a tearing pain, very sharp, and between the shoulder blades on the back, and he is a poorly controlled hypertensive. Blood pressure is 175/95 in the right arm. Heart rate is 110. Left arm blood pressure is much lower, 120/70. What is the answer? Aortic dissection. Why? Prematurely closing that this is acute coronary syndrome due to high blood pressure and severe pain, giving aspirin and heparin would be fatal because in aortic dissection, you are not supposed to give anticoagulants. If you dub it as ACS and give him anticoagulation, you end up in danger. What you have to do? Tearing pain, radiating to the back, somatic wiring profile, apply hemodynamic dashboard, slide 6. There is pulse deficiency is there. Blood pressure on one side is higher, other side is lower. Diagnosis of aortic dissection, one of the big 6. In fact, the worst of the big 6 is aortic dissection. It recently happened to one of my Guruji's son-in-law. And he is an, Adhyatmic teacher for us, and his son-in-law in Bangalore. He had similar presentation at midnight. Immediately we did a CT aortogram and found out aortic dissection and saved him. Okay, clinical case 3. A 35-year-old female, no past medical history, intermittent sharp, localized left-sided chest pain, worse when taking deep breath or moving the body. Vitals are low. Now, what is this? This is not atypical angina. It is a non-cardiac chest pain. Somatic wiring is affected. Pleuritic, reproducible with pressure. Heart score is 0. History 0. ECG 0. Age less than 45. Risk is 0. Drop is 0. Total score. What I do? Major acute coronary event risk is less than 1.7%. So safe for intermediate discharge, immediate discharge without expensive imaging or prolonged admission. Avoids overutilization of already constrained resources in this country. Now, pillar 1, terminology. What did we learn till now? Don't use typical atypical wording. Use cardiac, probably cardiac, non-cardiac. Biology, differentiate autonomic pain, autonomic visceral mesh of chest cardiac pain from sharp somatic wiring of musculoskeletal disorders. Dashboard, physical examination must target hemodynamics, blood pressure, pulse deficit, murmur at the root of the aorta, murmur at the apex. Check bilateral pulses, listen for new valvular catastrophe. Triage, filter the big six, life-threatening ones first, then use the heart score, which I have already told you, to drive objective decision making. With this, we will finish the first module. All these are based on your standard textbooks and the AAHC, AHC, and ACC or European Society of Cardiology guidelines only. Now, what is the next? This one, 12-lead ECG, high sensitivity troponin pathways. Objective investigations, algorithms in acute chest pain, a time critical diagnostic window. What is the pearl from me? Diagnosis of chest pain is not about predicting what will happen to this patient in future, but about aggressively narrowing uncertainty in the present. You live in the present. Don't think of what will happen to him day after tomorrow. That we will see. First of all, I must narrow myself to the right diagnosis in this Vartamana, in the present state. That should be your objective. Now, time is muscle. This is commonly told punchline. Time is muscle. The temporal window of intervention. You must acquire an ECG within 10 minutes. Immediate ECG acquisition to identify reperfusion mandate. Does he require an immediate cath lab intervention? Like that, ST segment, coving and elevation as you see. Then 1 to 2 hours, this is called the biomarker window, biochemical window. Order high sensitivity troponin. Don't use ordinary troponin or the cord test like pregnancy test. Don't use them. Use the venous blood to get high sensitivity troponin. At what intervals? 0, 1, and 2. Diagnostic pathways, advanced diagnostic pathways, or accelerated diagnostic pathways, ADPs, to detect necrosis kinetics. What does it tell the troponin? Troponin tells that the heart is crying for help. It doesn't tell you why it is crying. It doesn't tell you that it is crying because of ischemia. There could be several reasons for troponin increase. That is why a delta or a 0, 1, 1 to 2 escalation is more important than the absolute value. The troponin biomarker tells you that there is necrosis of the heart muscle, and it tells you that heart is crying for help. What is the post-triage? The anatomical window. You must do focus. What is focus? Point of care ultrasound. Here ultrasound means echo. Point of care ultrasound. Using the ultrasound only, do an echocardiogram. Or coronary calcium evaluation. Or do a regular echocardiography. Focus, CCTA, and echocardiography. Time critical algorithms fail when terminology is vague. Always document possibly cardiac rather than atypical to keep the diagnostic rigor. Abandon typical atypical classification. Adopt cardiac, possibly cardiac, and non-cardiac. then the 10-minute window is highly crucial. Class 1 recommendation: 12 lead ECG must be acquired and interpreted within 10 minutes of arrival of all patients with possibly cardiac chest pain. What will happen? Yeah, 10 minutes. We have taken the ECG, STMI, ST segment elevated myocardial infarction or equivalent. That is LBP is there. New onset LBP. Immediate cath lab activation. No chance. We have saved my co-brother by following this protocol when he had chest pain at the breakfast table. Immediately I am having ECG at home. I did an ECG within first 7 to 8 minutes we got the ECG and it is typical ST elevation. Immediately rushed to the hospital which is just across the road from my house. And within 35 minutes we reperfused him and he was completely saved. Otherwise he would have died. This is, we triaged him rightly because we identified STMI in the first 10 minutes itself. Then within 1 hour, the golden hour, you have to try reperfuse him. Now, the ECG does not show diagnosis of STMI, but it is non-STMI ACS or non-diagnostic. There is no typical ST segment elevation or any new onset branch block. Then you do the biomarkers. This is called the accelerated diagnostic markers. ADPs you have to do. I told you one single value of troponin is no use. Don't depend upon normal troponin. Do only high sensitivity troponin. What do I do? 0, 1 and 2. And it must show a rapidly increasing trend and the delta, the difference between 0 and 1 and 1 and 2 should be very significant. What is the clinical pearl? Single normal ECG never rules out myocardial disease. Serial ECGs every 15 to 30 minutes. If you have a monitor, connect him to the monitor and you can see the serial changes. Ongoing ischemia, recurrent symptoms are mandatory to catch dynamic changes. Don't depend on single ECG if it is normal. If it is already abnormal, there is no problem. You can triage him according to the two ways that is there, STMI and NST-ACS. Okay? Now, what are the three typical things that can occur in the ECG? Look at that, a coving ST segment elevation followed by not deeper TPT inversion as such. Convex morphology is highly specific of acute transmural through and through myocardial infarction. This is called acute coronary syndrome, STMI, ST segment elevation myocardial infarction. The second one in here is the ST segment depression. Horizontal or downsloping depression indicates subendocardial ischemia, not through and through. This is called NSTEMI. Today it is not called MI, it is called NSTEACS. That is non-ST segment elevation acute coronary syndrome. Nothing wrong even if you say NSTEMI. But general terminology today is NSTEACS. And the third one is deep symmetrical T inversions without ST segment changes. This is called Valence syndrome, born of critical proximal LAD stenosis. LAD stenosis may not present with typical ST segment elevation. A deep symmetric inversion of the T wave, critical LAD stenosis. Immediately you should go to the cath lab. Look at the company the ST segment keeps. Always it is important. You can see if you know the company, you know what is going on. Now, a true ischemic event, there will be ST elevation in the chest leads, means there will be V3, V4, V5 ST elevation, L1 AVL ST elevation. Complementary changes will be there in the inferior leads. So this complementary or reciprocal changes you must always observe. This is what is called the company the ECG leads keep in line with that. Now, I am classifying them as STMI, convex, focal, elevation in two contiguous leads at least. PR segment is very, very important. Not many of you will give importance to the PR segment. PR segment is normal. There are reciprocal changes present which are highly specific for STMI. If the left-sided leads are showing ST elevation, inferior leads are showing the reciprocal changes. Acute pericarditis, concave, diffuse elevation. Here also there will be elevation, but it is concave, but not in one lead. Entire ECG, all the leads will have this one. There is a the PR segment is depressed. This is the catch. In acute pericarditis, all the leads will show ST elevation and PR segment is depressed. This is called Spodik's sign in the ECG. No true reciprocal changes except in the AVR and V1. So all the leads show uniform elevation of ST segment. There is a depression of the PR segment. Normally you don't give importance to that. What is PR segment? The part of the ECG from the end of P wave to the beginning of the R wave is called PR segment. Left bundle branch block. Patient does not have any other thing. There is a discordant QRS complex. Left bundle branch block is there. PR segment is normal. Apply the criteria of Sarbosa criteria to rule in ischemia. What is Sarbosa criteria? I'm not going into details here. When we discuss about ECG, we will talk about. Early repolarization, concave ECG, like this, cup-shaped, prominent, J-point notching, PR is normal, young healthy patient demographic, non-cardiac chest pain. Professor's clinical peril, PR segment depression in multiple leads is the catch, hallmark of pericarditis. Always check AVR, it will show reciprocal PR elevation. Now, look at the delta concept. This is a new concept. What you have to do? Not the regular troponin. You have to do high sensitivity troponin. High sensitivity C troponin. C troponin is cardiac troponin. You have to write HSC troponin. High sensitivity C troponin. This detection threshold, first sample 0, 1, 2, 4 like that. Troponin starts elevating within half an hour to 1 hour, and the delta between 0 and 1 and 1 and 2 is very profound. Standard troponin assays will take time to show elevation. So don't do the standard troponin. High sensitivity assays are brilliant for early rule out because their massive negative predictive value. If there is no delta increment between 0 and 1 and 1 and 2, the high sensitivity troponin is almost the same. You can safely exclude acute coronary syndrome. Such is the utility of this high sensitivity troponin. Then what do? 0 hour blood draw. As soon as the patient comes, one nurse will be drawing the blood and another nurse will be placing the leads for the ECG, and you will be inquiring about the symptoms and listening at the heart and palpating the pulses. You distribute the work. Don't do one after another, do simultaneously. Rule out very low initial or minimal delta after 1 or 2 hours. It is safe and early discharge from outpatient workup. Rule in high initial 0 value or a significant delta between after 1 and 2 hours. It is a rule in the disease. It is red flag. Suppose it is in between. Values fall between rule out and rule in thresholds. Wait. Proceed to the third draw, 0, 1, 2, 3, the third draw. Integrate the clinical risk scores, use the heart score, use the Gray score, which I am going to show in the next slide. Now, what is the clinical part? European Society of Cardiology, 0-1 algorithm is very safe, very fast, very validated for high sensitivity assays. Never attempt to do this 0-1-2 on normal troponin. Now this is that heart score, total of 10. What is there in the heart score? History, of course, troponin, ECG, risk factors, age. Each one has got 2 points. Total 10 points. If the risk is between 7 to 10 points, high risk, 50% of major acute coronary catastrophe. That means he may die also. Early invasive strategy. The risk factors are between 4 to 6 using the heart score. The major acute coronary events are 16.6%, admit, observe, non-invasive imaging, low risk scoring. 1.7% major acute coronary events at 6 weeks, you can safely discharge. This is the normal risk anybody has got. 1.7% is a very low risk, isn't it? Now, what is the clinical pearl? Heart score was pioneered specifically in emergency department chest pain populations. It has been validated and in Holland in a great study. It explicitly empowers you to send a low risk patient home without a need for a stress test or further imaging. This excludes patients of low risk and allows you to send them home. You must do the heart risk scoring. Now, type 1 MI, type 2 MI, non-coronary myocardial injury. What is type 1 MI? Coronary plaque rupture, thrombosis, acute rise and fall, significant delta in the drop, and then differentiating myocardial injury. This is called troponemia. That is circulating troponins. Troponemia is circulating troponins. What is the treatment for type 1 MI? Antithrombotics, revascularization. Type 2 MI, ischemic supply demand mismatch without acute atherothrombosis, severe tachycardia, profound anemia, acute rise and fall. Treatment fix the underlying demand driver, particularly beta blockers. Non-coronary myocardial injury, directly toxic, inflammatory, strain-related injury, sepsis, pulmonary embolism, renal failure, myocarditis. If you may be asked to write a short notes on troponins. First line you write, I will not do normal troponins. I will do high sensitivity cardiac troponins. What intervals? 0, 1, 2 if necessary, third hour. How do I classify the patient with a higher delta and a high initial value as type 1 and go for antithrombotics and revascularization? I have an intermediary patient who has some delta but not totally convincing, and then fix the underlying demand driver. Then there are other non-myocardial, non-ischemic causes of troponin elevation. What are they? Pulmonary embolism, sepsis, renal failure, myocarditis. Here the troponins will be elevated, but there is no delta. That means there is no hour-to-hour increment. Often chronic, blunt elevation without a sharp delta. Treatment, manage the primary illness. Now you see, troponin is organ specific. Cardiac troponin tells about heart only, but not disease specific. It tells you the heart is crying, but it does not tell you why it is crying. The child is crying, the child is crying, but the cry doesn't tell you why she is crying. Is there an ant bite, or she is having pain in the abdomen? For what reason the child is crying? That you have to find. Do not reflexively give heparin just because the troponin is elevated. Why? Troponin can be elevated in acute aortic dissection also. Giving heparin will jeopardize the life of the patient. How important it is to look at the clinical signs. The two arms blood pressure, the fall of blood pressure, one side it is high, other side is there is a new murmur, aortic area, aortic murmur, high uncontrolled hypertension, sharp tearing pain, like something like a somatic pain there in the interscapular area. You are in for aortic dissection. Don't simply give heparin just because there is chest pain. Then what are the imagings I select? There are three types of imagings are possible. One is a chest X-ray, the other is a bedside focus, the third one is a CCTA, coronary CT angiography. CT angiography. CCTA means coronary CT angiography. Okay. Chest X-ray, baseline chest X-ray must be obtained, but not in the immediate first one. Rule out the immediate structural alternatives, pneumothorax, pneumonia, wide and mediastinum due to aortic dissection, other respiratory causes. You can exclude by doing a chest X-ray. Bedside focus, point of care ultrasound. Focus is point of care ultrasound. It is a beautiful hemodynamic tool. For what? To evaluate undifferentiated shock or suspected structural emergency, cardiac tamponade, massive pulmonary embolism. CCTA, that is coronary CT angiography, anatomical rule out. Intermediate risk patient, possibly cardiac pain, where functional testing is equivocal. Functional testing means your heart score, your clinical examination, and your ADPs. That is the accelerated diagnostic protocol. So in 2024, imaging is not a shotgun approach. Select the modality that answers a specific binary clinical event. Now, so what views I should get with the focus? Parasternal view, access LV function, and screen for regional wall motion abnormality. Even before the ECG changes appear, even before the troponin rises, wall motion abnormalities are the first one to be detected. So if you do a focus and see regional wall motion abnormality in many of the cardiac chamber valves, it is diagnosed. Then you have to put at the four-chamber view. Assess the right ventricular strain, McConnell sign, indicating massive pulmonary embolism. Subcostal view, that is here. Subcostal view is this. This is the four-chamber view. This is the parasternal view. Fastest window to rule out pericardial effusion and cardiac tamponade. Just put in the three places the probe. Finished. You have got the answer. Is there RWMA, parasternal view? Is there a LV right ventricular strain suggesting pulmonary embolism? Is there a pericardial effusion, cardiac tamponade? Regional wall motion abnormalities appear on an echo seconds after the blood flow stops. In acute coronary syndrome, ST elevation, long before the ECG changes or the troponin changes. Focus is your earliest ischemic detector. Now, dive deep. Guideline integration 2021 AHA-ACC guidelines, class 1 recommendation for intermediate risk patient, acute chest pain, no known CAD, CCTA. When I do a cardiac CT angio, clinical utility, exceptional negative predictive value. Means what? If ECCTA is negative, it rules out anatomical CAD and allows you to safe discharge. Okay. CCTA provides an anatomical certainty. A treadmill test tells you whether the engine is struggling. A CT scan tells you exactly where the pipe is blocked. The difference between the two tests. The treadmill test tells you whether the engine is struggling to hold the stress. CT scan tells you where the pipe is blocked. Now, triage. 0 to 10 minutes if STMI, cath lab. 0 to 2 hours, HS, cardiac troponin, especially the ADP applied. The delta is looked at. The increase in troponin, heart score is calculated. Triage into 3 groups. Low risk, negative delta, 0 to 3 score, safe to discharge. High risk, more than 7, admit, heparin, cath lab. Intermediate risk, CCTA or functional imaging or focus, and then look at the next step. Expert clinical reasoning does not rely on a single test. If you are a really good expert, don't rely on a single troponin or history or CT or any of the things. It relies on a sequential filters that progressively reduce pre-test probability to 0. What are the key takeaways of the second part? 10 minutes, within 10 minutes, I must get ECG. This is non-negotiable. Trust the troponin delta. Elevated troponin without acute plaque rupture in type 2 patients and myocardial injury can occur. Elevated troponin alone is not sufficient. I must demonstrate a quick increase in the delta. Integrate the heart score with ESC ADPs to confidently discharge a low-risk patient. Algorithms and ESAs are magnificent tools. Nobody denies. But they cannot replace you. These algorithms, these tests cannot replace you. The single most powerful diagnostic instrument in cardiology remains a sharply taken clinical history. What else I should tell? Now, how do I approach the patient and how do I emergency pathways, clinical application. 3 types of people: heart score, TIMI score, GRACE score. Go and read about these things. Heart score, I have told you. TIMI score, there are 7 clinical variables are there. GRACE score, 8 variables are there. Requires a digital calculator. This is available on your mobile phone. Type Medical, MEDICALC. Medicalc. There is an app. Download that app. Go to the GRACE score and punch the number, variables they want. 8 variables, you get the score. Likewise, heart score is simple. You can yourself do it. You do not require a calculator or your mobile phone. TIMI score also, this is available on the app. Once again, I am repeating, Medicalc, MEDICALC, or Medcalc, that also is good. The heart score is your shield for safe discharge. GRACE is your roadmap for inpatient aggressiveness. Heart score is to exclude 0 to 3 risk score and send them home. GRACE score is to go for inpatient aggressiveness. Clinical assessment, 10-minute ECG, STMI, cath lab, activate the cath lab and perfuse. No STMI, do the initial HS troponin and then 0, 1, 2 hours accelerated diagnostic protocol, and that is rule out negative increase in the heart. There is no increase in the troponin. Low heart score, early discharge. Or NSTE ACS observation category, that is the intermediary category, that is probably cardiac, admit to telemetry and observation, bedside echocardiography, non-invasive anatomical imaging without doing a conventional angio, do a CCT, cardiac CT angio, or a functional stress testing, without asking the patient to go onto the treadmill, you can do a functional test. Here, what is the pearl? Relying on a single troponin is a gamble. Serial HSCTN C-troponin protocols evaluate the delta. We are looking for kinetic rise in the active infarction, not an absolute value. Now you see what particular test for what. You see there is a plaque, initial endothelial disruption. What I have to give? Aspirin, clopidogrel. Zone 1, platelet plugging. You have to stop further rupture of the plaque. Zone 2, fibrin mesh has already formed and RBC and other blood cells are entangled. Thrombosis is ongoing. Treatment is anticoagulants, unfractionated heparin, low molecular heparin. Clearly understand what you are doing. For platelet pluggers, like antiplatelets, aspirin and clopidogrel, or for the endothelial disruption. Fibrin mesh, ongoing thrombosis should be treated not only with platelets, you add on unfractionated heparin, conventional heparin, or low molecular heparin. And the third one is vessel wall is damaged, vasospasm, ischemia, increased myocardial oxygen demand. Treatment is anti-ischemic. Nitrates for vasodilation, beta blockers to reduce the cardiac demand, chronotropy, and oxygen if required. You see the vessel and treat what is happening in the vessel. Now, patient 1, 58 years male, presents with crushing substernal chest pain, profound diaphoresis, radiation to the left arm, symptoms onset 45 minutes prior to ED. Look at the ECG, a typical ST segment elevation in V2, V3, V4. There is a V1 to V4 reciprocal changes are there. These are elevated, and you see the reciprocal changes also are seen in the other leads. Action plan: acute anterior STMI, immediate dual antiplatelet loading, therapeutic anticoagulation with low molecular heparin, cath lab activation, 90 minutes door to balloon. The moment you have come here to the balloon time, 90 minutes you must finish it. This is a very important time frame. So because time is muscle, time is myocardium. Do not wait for the troponin if the initial ECG shows clear STMI. You have taken the blood. Don't let me see when the troponin result come. Then no. If the ST segment elevation is already there, munjeti kankanamunaku addamela. Supposing I have a watch, should I see it in the mirror or directly see like this. If the ECG is already showing ST segment elevation, why wait for TROP or CCT or other coronary and CT or something? Not required. Most important thing is case number 2. You see 60-year-old man, hypertensive emergency, presents with sudden maximal intensity, 10 by 10, tearing pain radiating to the interscapular area. It is not acute coronary syndrome. It is aortic dissection. Clinical picture, initial ECG shows non-specific ST changes. Don't dub it as NSTMI. D-dimer is elevated because of the ongoing bleed. Initial HS and high sensitivity troponin is only mildly positive. There is no delta increase. The case is aortic dissection. You should not give anticoagulants, antiplatelets. Immediately you should go for surgical repair. Acute aortic dissection requires immediate bedside focus to evaluate the pericardial effusion, aortic dilatation, a diastolic murmur here, followed by emergent CTA of the aorta. That is, trap here, administering potent antiplatelets and anticoagulants for presumed NSTEMI before ruling out aortic dissection is a sin. God will be noting from above how many sins you have committed in your profession. Depending on the sins, the punishment will be there. You see, take care of that. Patient vignette, third case, 65-year-old patient reports reproducible exertional chest pain. That means if I press, the pain is coming back. Tightness after walking 2 blocks, consistently relieved by 5 minutes or less. It is not by pressure, reproducible by exertional. If you give him 5 minutes of exercise or walking, he gets the pain. This is what baseline is normal. Serial troponins are flat and there is no delta increase. Heart score is low. What is that patient? Transition from emergency pathway to SIHD. That is now today it is called stable ischemic heart disease. We don't call it as angina anymore. We call it as stable ischemic heart disease guidelines. We have to follow that. Medical optimization, beta blocker should be there, statin should be there, safe for discharge with arranged outpatient functional testing and also CCT. And do a treadmill and also you do a coronary CT angio. Not all chest pain needs inpatient bed. Don't try to admit every fellow with chest pain into the bed. There are no beds. Mastery is knowing when it is safe to pivot to robust outpatient diagnosis pathways, when it is essential to put the patient in. Okay, the patient vignette. Another case number 4, 70-year-old male with 15 years history of poorly controlled type 2 diabetes, sudden unexplained exertional dyspnea, no chest pain, came with exertional dyspnea, denies any chest pain or tightness. This is angina equivalent. Anchoring primarily prematurely on pulmonary etiologies, he is having dyspnea, so must be having a lung problem, COPD, pneumonia. Not the way you should look at it. Silent ischemia manifesting as anginal equivalent, highly prevalent in diabetics, women, and elderly. How they come? With exertional dyspnea, sudden exertional dyspnea, diaphoresis. Mandates a full AC workup, immediate 12-lead ECG, serial troponins, strict application of the risk stratification matrix. Don't dub it as pulmonary cause. Now, you have 3 a.m. duty hour. Somebody called you at 3 a.m. Within 10 minutes, vitals are checked, ECG is taken, STMI is there, cath lab. No STMI, calculate heart score, draw second blood for the first already 0 hour drawn, 1 hour also you do. Then high risk because of the heart score, positive, rising troponin, and STMI pathway, admit, acute arsenal, medical arsenal, and major strategy. Or intermediate pathway, intermediate scores, non-diagnostic ECG, admit for observation, echocardiography, non-invasive CT. Or very low risk, doesn't have 0 to 3 heart score, troponins are not rising or negative, rule out the diagnosis of acute coronary syndrome, safe for early discharge. Now, the diagnostic track. A normal ECG rules out active ischemia. This is what you think. It is not correct. Up to 20% of the NSTE ACS patients present with a normal initial ECG. Then what do I do? If the initial ECG is normal, I take a serial ECG every 15 minutes, 30 minutes, or I put him on the monitor. Pain was completely relieved by GI cocktail. Somebody has given antacid and then PPI, some domperidone, there is some relief. Remember, the lidocaine and the antacid can coat the esophagus and reduce the cardiac pain also. Antacids might relieve. The GI cocktail might appear to give some relief. Symptom relief is not to rule out ACS. Pain is described as atypical by somebody and it is non-cardiac. That terminology is outdated. Guidelines explicitly advise abandoning the word typical, atypical. Precise descriptors are cardiac, possibly cardiac, and non-cardiac. This clinical truth you have to follow. The diagnostic trap on the left side you have to avoid. Now, postgraduate academic reading list. What should you read? So, of course, the 2021 ACC, ASC, chest, ESEM, SCCT, SCMR guidelines for evaluation, diagnosis of chest pain. Just type that number. You will get that. 2023 European Society Cardiac Guidelines for the Management of Acute Coronary Syndrome. Foundational text, your Harrison's Principles of Medicine, 21st edition, 14th chapter, chest discomfort. Go home and read that chapter now. Barnward's Heart Edition, 12th edition, chapter 35, Approach to Patient with Pain. You may not have the book with you. Go to your library and read Barnward. We used to read Barnward in our student days, not Harrison alone. The landmark evidence is chest pain in the emergency room. Value of the heart score is indispensable. Netherlands Heart Journal has published in 2008 the heart score. You can just type in the Google heart score Netherlands Journal 2008 to get the full paper and it will tell you how much it is valuable. These are the resources you must consult. Now, this is the final take-home slide. What is my take-home message? Number one, systematize your approach. Don't be very casual and sort of erratic. Standardized pathways, 0, 1, 2, high sensitivity, cardiac troponin, risk scores, heart score, gray score, to strip off emotion. Don't think that you are fatigued at 3 a.m. Don't be biased that it is gas trouble or something. These things, emotion, fatigue, and bias will cloud your decision. Respect the fatal mimics. Always actively rule out acute aortic dissection and pulmonary embolism, two life-threatening emergencies than even acute myocardial infarction before anchoring on the acute coronary syndrome diagnosis. Time is muscle, time is tissue. Swiftly execute acute medical arsenal in intermediate and high risk cases. Hesitation cause myocardium. If it is STMI, early cath lab, immediate reperfusion. If it is non-NSTMI, antiplatelets, double antiplatelets, aspirin, clopidogrel, anticoagulants, and G2B3A inhibitors, and then evaluate fully. Clinical reasoning over remote memory. Treat the patient, not the troponin. Because troponin can raise in many other conditions which are not ischemic events. I told you the raising troponin is the catch. Recognize anginal equivalents. Patient may not come with typical chest pain, radiation and all. Particularly women, diabetics, and then elderly people will come with angina equivalents. What are they? Diaphoresis and then exertional breathlessness out of proportion to the exertion. And also upper abdominal symptoms like vomiting and nausea should point out that could be angina equivalent. Your ultimate goal is not to have all answers the moment you walk into the emergency room. Nobody will have it. Even with 52 years of experience, I don't have all the answers for all the patients. But apply a clinical blueprint so flawless that the correct answer reveals itself. If you go the clinical blueprint I have shown, flawlessly apply it, the correct answer will reveal itself. You don't have to do anything special. This is my take home. With this, I close this presentation.